Welcome to Medicine in Our Backyard. This is a series that's presented by the Newport Beach Public Library Foundation in partnership with UCI Health. My name is Adrienne Windsor. I'm a member of the board of the foundation, and I love introducing this series because I've learned so much. So, we want to thank our generous sponsors, Mike and Polly Smith. They have sponsored this program since its initiation, which has been now for almost a decade. And it's been an amazing resource to bring into union the community with the wonderful expertise that we have at UC Irvine, and to have them share their knowledge with us. So a quick bit about the foundation. How many of you are members? Well, that's good. We are a membership foundation. If you aren't, we'd love it if you became a member before you leave tonight. We sponsor many things for the library that the city doesn't provide. The very chairs you're sitting in were a gift from the foundation. Many of the e-books that we were very important during the pandemic because people couldn't come into the library, and our resources really were very, very useful. We sponsored the Media Lab. I don't know if you've been in there. Are you aware that you could go in and record your memoir for your grandchildren? And do it on your own. All you have to do is make an appointment, and you can go in and you have your own sound studio. So we provide many opportunities, and we love it if you become one of us. You also are the first to learn about our witty lectures and our Library Live lectures. And we have a Library Live lecture coming up this very Thursday with Bill Platschke, who is a columnist, sports columnist for the LA Times, and he's going to be talking about the football team what should we say? That not only survived but triumphed over that terrible, terrible fire that wiped out the whole community. So come on Thursday night and meet him and listen to him. Now, a few reminders. If you haven't silenced your cell phones, please do that now. And we will have Q&A after our speaker. So if you have questions, please hold them. And one other thing I like to do, I'd like to thank Kunga and Jane. Kunga is our program director here at the foundation. Jane is with UCI Health. And they organized this program. And also tonight, we have a special guest. We have the chair of the foundation, Karen Clark is here. Karen? And our CEO, Jerry Capel, is here in the back of the room. And they share with me in being grateful that you are here. So now I am pleased to announce tonight's speaker. I hope you can hear me. Our speaker is Dr. Hamid Djalilian. He is the director of UCI Health, Otology, Neurotology, and skull-based surgery. He said it's okay to say ear, nose, and throat. Those words are a little easier. He's with the UCI School of Medicine and Biomedical Engineering and the UCI Samueli School of Engineering. He earned his medical degree from the University of Minnesota and completed his residency at the University of Minnesota Hospital and Clinic of Ear, Nose, and Throat. He completed his fellowship in neurotology and skull-based surgery. And tonight, he's going to speak to us about understanding hearing loss and the latest treatment options. So please join me in welcoming Dr. Djalilian.
Thank you so much for that very kind introduction. Let me just make sure this works. So I'm going to talk a little bit about some other ear-related conditions because that's sort of part of my specialty and thought might be of interest, which will include a little bit of dizziness and balance-related issues as well. So a quick overview of how the ear works. switch here. What sound is basically molecules of the air vibrating. So I'm creating vibrations in my voice box. I manipulate those sounds with my mouth and tongue. That goes into the microphone, the air molecule movement. Then it goes into the speakers, and then that projects larger movements of air molecules. So then it reaches your ear. And then when it reaches your ear, these movements of the air molecules will vibrate the little eardrum we have at the end of the ear canal. That then vibrates these 3 little bones. And the function of these bones is actually amplify the sound a little bit. And then when the sound gets to the inner ear, which is that thing that looks like a snail, that thing is filled with fluid. And so then the fluids will start vibrating. And we have these tiny little cells in there. They're called hair cells because they have these microscopic little hairs on top of them. And then that vibration of the liquid will then vibrate to those cells. And then those will then send the signal to the brain about the pitch of the sounds that you're hearing. The brain then puts that information together and figures out what each of those words mean. And what's amazing is how quickly all of this happens. I'm speaking and instantaneously you understand what I'm saying, but that's quite a bit of process. It has to go through multiple sets of nerve cells from the ear all the way up to the brain, and then get that interpretation, and then actually then it goes to the other parts of the brain like memory, etc. Okay. We're going to primarily focus on this part of the whole deal. The nerve of the hearing is here. Along with the nerve of the hearing, there are 2 nerves for balance which also come in and supply this part of the inner ear, which is the balance organ. There's one more nerve that comes through here, then I deal with problems of that, which is the facial nerve, the one that moves the face. So that nerve comes in here, it travels actually through here, and then it goes through this bone, and it comes out in front of the ear, kind of down here, and then spreads to the face. Now, if you've ever had a hearing test, you're familiar with this diagram, but in case you're not, we'll give you a quick overview. So when you get a hearing test, you'll see something like this, and then you're going to have level of hearing on this side. So we want ideally all the symbols to be up as high as possible because that's what normal would be. On sort of this half, on the left half, are like low pitch sounds, which would be like similar to, like, if you want to think about it, like a male voice. And the sounds on the right side are more like high pitch sounds, and they're kind of more like a female voice. Now, technically, I should say it's, male and female voices really are across the entire spectrum, but there's more sound on the low end in men and more sound in the high end in women. So just to give you a frame of reference, this is 250, which is approximately the same as the middle C in the piano. So middle C in the piano is 256. This is 250. And every doubling of that number is 1 octave above. So 4,000 is the last key on the right side on the piano. Okay, and now our hearing is actually much broader than that, because if you think about it, there is the left half of the piano I haven't talked about. And the left half of the piano would be these octaves going downward this way. So our hearing is from 20 hertz to 20,000 hertz. But we test only 250 to 8,000 because that's what's most important for speech. Now, this is some common sounds and what each is and sort of the frequencies and whatnot. Now, in general, the vowel sounds are all in the low pitches. So you see the A, O, I, and E, and U. And the consonants are mostly in the higher frequency. Now, the highest frequency sounds are the F sound, the S, and the TH, the th sound. So if you have a high-pitch hearing loss and someone says fat or sat, like as in sitting, or fat as in obese, then those are going to sound the same because F and S are really high-pitch. And if you have a high-pitched hearing loss, you're not going to see, you're going to miss that. And so you have to look at the individual's lips to lip read. And that's what we often do when we have some hearing loss, is we automatically, our brain will start doing lip reading. Now, a whisper is approximately this 10 to 20, so this is like a whisper. Although that's to monkeys whispering, they're just the same as humans whispering, I should say. And then a conversational speech is between 40 and 60. Now, my voice through the speaker system is probably reaching your ear around 70 or so. And we were talking earlier, because a lot of my patients have hearing loss, I tend to speak more loudly, and so I have to kind of control myself to not speak very loudly, especially when I get home. My wife's always like, stop yelling at us, we hear you. So just a general conversational speech level, so depending on where your hearing is, if your hearing is, let's say, this level here, then a conversational speech is going to sound like a whisper to you, so it's going to sound really quiet. So sometimes when you have hearing loss, if you cannot hear, you have to actually use a lot of brain power to make out the words, because you're not getting all the words, so you just get little bits and pieces, and your brain has to put that information together, make sense out of the sentences. And a lot of times people with hearing loss, at the end of the day, they feel very tired mentally, because they have to expend so much energy thinking about things unconsciously. And then sounds that are way down here are sounds that can cause damage to hearing. And if you went to a lot of concerts when you were younger, or you're still going to concerts, then you can potentially damage your hearing. Shooting guns and other things will cause damage to hearing. So these are the situations where you want to be wearing hearing protection. Shooting, definitely double protection. So if, let's say, somebody has a hearing like this, they're going to have problems hearing these sounds, like the F and S, and as we were talking about. Now, hearing loss is very common. It's actually 1 in 10 individuals in the US has it. It, of course, occurs more as we age. It's the most likely thing to go wrong in a child that's born. So a child being born, the most likely thing that might be wrong is that they will have hearing loss. When we think about all these other things that can occur, those are all tiny, tiny little percentages, and 1 in 10,000, 1 in 50,000. But a child being born deaf is 1 in 1,000. A child being born with some hearing loss, it's 3 in 1,000, so 1 in about 330. It is the #1 birth defect, as we talked about. And picking up this hearing loss early on is really important, because if we miss this time window of picking it up and treating it, then that child is very much more difficult for that child to be able to function well in society. Because of the educational system, even though there is an educational system that sort of runs in parallel for patients who have severe hearing loss or deafness, they never achieve the same level of reading as a hearing child will. So usually at the end of high school, an average hearing child is usually at least 3 to 4 grade levels above a child with hearing loss. And the cost of educating a child with hearing loss is substantially higher. So it's important that we pick these up early. Now, in children, hearing loss can be restored in more than 90% of them. So if they have a functioning nerve and their inner ear is okay, we can actually place this device in their inner ear. What causes hearing loss in children oftentimes is genetic problems or infections while the mother is pregnant. So in utero infections and genetic issues is what causes those cells that pick up the sound, the hair cells that pick up the vibrations. Those are the ones you lose, but your nerve will remain. The nerve will remain intact, and so you can stimulate that nerve electrically, and then you can the child will learn to speak and all that. So this is a device called the cochlear implant, and we use it for children. Of course, we use it for older adults too. So in adults who understand less than 50% of words with hearing aids, then a cochlear implant will oftentimes do better for them than if they were to just use their hearing aids alone. And the way that the cochlear implant works is instead of the cells electrically stimulating the nerve cells, is that you actually have an electrode in there doing that. And because our inner ear is shaped such that the low pitches are on one end and the high pitches are on the other end, then the device can be programmed to kind of give you the speech, and people generally do very well if they're, if we pick the right candidates for this. So today I saw a child that we had implanted many years ago. He's now 19, and he's going to college, and you have a conversation with him, you can't tell he has any hearing loss. But he takes his implant off, he won't hear anything, So one of the things that we try to do at sort of my capacity at the university is not only to, of course, treat patients, but also do things that we can do to help prevent diseases. And hearing loss is one of those things that is preventable in many individuals. Now, the things that we cannot control are age-related hearing loss, and we'll talk about what we're doing about that. But what really noise-induced hearing loss is a big problem, because all noise-induced hearing loss is permanent. So if you play with firecrackers when you're 10 years old and you get some hearing loss, that hearing loss will stay with you for the rest of your life. And it won't show up on a hearing test when you're 10 because you have so many cells that the test will appear normal. But then when age-related hearing loss hits, usually between age 40 and 50, then we see a substantial sudden drop in the hearing level because all of these losses of hearing accumulate on top of each other. And so if somebody has diabetes and they have high blood pressure, those will cause hearing loss. All of these things will stack up on top of each other, and then people lose hearing at a much faster pace. So we want to be able to tell children early on that the noise can damage hearing. Part of what we do actually on a yearly basis, we actually test new toys that have come out and send a sort of a press release so that they can, the news outlets and media outlets can tell people about them. So this is one of the studies we did a few years back where we were testing these various types of devices. We hook up microphones and fancy sort of devices to measure exactly how much sound output comes. And it's amazing that some of these toys are producing sound, not only they're sort of way above what they're supposed to be, but they're actually at a level that if a child holds it up to the ear, which a lot of times children do, is that they can actually damage their hearing. And this would be like a 1-year-old could potentially damage their hearing. And so I'm, of course, I test this stuff on a yearly basis, so I'm familiar with some of these very loud toys. And somebody gave one of these toys, these very loud toys, as a gift to my daughter when she was like 1 year old. So the first thing I did is I just took a whole bunch of glue and taped over the speaker so that it can reduce the output. But what the tendency is, the children want to see where the sound comes from, so they keep playing with it and kind of putting it up against their ear. So the testing that's sort of the standard testing is to hold it a foot away, but a young child never plays with it the way a toy manufacturer labels it at. And then this was an article in CNN a few years back on another study that we did looking at what kinds of things cause hearing loss and whatnot. So hearing loss is common as we age, that it's a normal process of aging. We have sort of what we call a programmed loss of cells in the inner ear. So those cells that pick up the vibrations will gradually be lost over the years. And as we lose those cells, then we will get more and more hearing loss. Now, what happens is sometimes when people have significant hearing loss, they tend to reduce their social interactions because it's very frustrating for them to interact socially, because in a noisy environment, people have much more difficulty when they have a high-pitched hearing loss, which is the most common type of hearing loss. So, but what's amazing is actually a lot of people who have hearing loss don't get hearing aids, even though hearing aids really could help them. And the main reasons are cost and the sort of stigma. For some reason, in sort of our culture, it's sort of become accepted that wearing glasses makes you look more intelligent. But wearing hearing aid doesn't make you look more intelligent. Now, I always say it's the same thing. You can't see without your glasses, you put the glasses on. It's become a fashion piece, whereas the hearing aids are not a fashion piece, but we're determined to make it a fashion piece. And of course, access is another issue. Now, hearing loss has been associated with dementia, not a causation, but an association, meaning that they found that people who have dementia, they have a much higher percentage of people who have dementia have hearing loss compared to the same age group individuals who don't have dementia. Now, whether the hearing loss is the cause or it's a part of the neurodegenerative process, or is it because people with hearing loss are just not socially interacting, so they're not getting as much the stimulation of the brain. We don't know. There's actually a large trial now currently to see if intervention with a hearing aid will potentially reduce the likelihood of dementia. But that study will take probably 5 to 10 years to get an answer. So we don't know yet, but we will know in the future. So there are some places that are, that try to sell hearing aids, and they will sort of say, if you don't get hearing aids, you're going to get dementia. That's not necessarily true. Patients come and tell me this information sometimes, and I say, well, we don't know yet. Hearing loss is associated with it. Does hearing aid prevent dementia? I don't know. But, if your hearing loss is preventing you from interacting socially, then get hearing aids. But if it's not, then you don't need to get hearing aids unless, other people are complaining about it, which a lot of times is the issue. So, as I said, a small percentage of people who actually have hearing loss are using hearing aids. There are some new things that may increase that number. Hopefully, we'll talk about that. So in the US, there's a relatively small number. That's only about 15% of people with hearing loss are using hearing aids. And a lot of people who get hearing aids don't end up using them, and a relatively smaller percentage is very, quote unquote, very satisfied. Now, the reason for the people who are not using them oftentimes has to do with people's expectations. So people expect the hearing aid to work like glasses. Glasses work because it's a refraction problem. It's just you just need to get the light focused in the right place. If your retina, sort of the part that actually has where it picks up the light and makes it into nerve signals and sends it to the brain, if there is damage there, glasses aren't going to help. But in hearing loss, most of the time the problem is the area where the nerve cells or the cells that are picking up sound, those have been lost. So the clarity will not be good. So people expect hearing aids to turn back the clock to when they're 20 years old, and that unfortunately doesn't occur. So what we usually like to do is if we set the expectations right, this is what to expect with hearing aids. You will still have difficulty in a noisy environment, but it's not going to be as bad as it is now without hearing aids. Then people have the right expectation, they'll do well. The other problem is a lot of times people use hearing aids, but then they have a problem with it, but they never go back to get those things adjusted. And a lot of those things are actually fixable on hearing aids. So over-the-counter hearing aids were just approved maybe a month or so ago. And it's intended for mild to moderate hearing loss in adults. The main advantage of an over-the-counter hearing aid is the lower cost. The primary disadvantage is that there are very few manufacturers that offer any kind of support. So you're basically getting them. You can get some very cheap ones, like $50 to $100 for hearing aids. But that's kind of all you're getting. You can't adjust it. You can't, if you have any problems with it, there's nobody really to help you. You're just buying it from Amazon or from the store. There are sort of the few manufacturers that have adjustment capability are done remotely. So basically, you have a little box. You put your hearing aids in. That box is connected to your Wi-Fi. And then the manufacturer, you say, well, I'm not hearing as well. So they say, okay, we'll just turn it up a little bit. So you put your hearing aids in there. Then they will program the box. The box will then program your hearing aids. And then you take your hearing aids back and put them in there. The only issue with it is that the hearing aids are really not tuned to your hearing level. They sort of have some pre-programs of what the most common types of hearing loss are. And then they will then have to make adjustments every time. The adjustments take time. So, let's say if you go to, you're getting hearing aids from a person, an audiologist, you go there and they will tweak it and you say, I don't like it. And then they tweak it a little more. But with the over-the-counter devices, it's multiple appointments. Like every time they make an adjustment, you have to try it for a while, and then you put it back in, and they got to program it overnight, and then it's not real time. It takes maybe several days of programming to try to get it right. I'm going to shift gear, talk a little bit about ringing in the ear, because ringing in the ears is also a very common problem in the United States. It is caused by hearing loss, so ringing is caused by hearing loss. It's the higher the age, the highest the prevalence, because there are there's more hearing loss as we age. It is the #1 cause of disability in the military, and on a yearly basis, $1.5 billion is spent just compensating veterans who have suffered ringing in the ear. So it's a very costly problem, and then there are 2 million people in the U.S. who are actually severely affected to the point that they are actually disabled. So it's a huge, relatively drain on resources if you think about sort of just the money that's spent on this problem. And there's really no cure available currently, although we're working on several things that we'll talk about in a minute. And then last, I'm going to just talk about imbalance a little bit. The inner ear balance organ, as I was mentioning, is what determines or tells our brain how your head is positioned in space and how to adjust muscles to sort of keep you upright. So if you get thrown in a pool, you can always tell which way is up. That's because of your inner ear. And if you were to look at that screen and kind of move your head back and forth, you can still read the text. It's not like your eyes are going to move all over the place. And the reason your eyes can hold still and still read the text is because your inner ears will very rapidly adjust your eye movement against your head movement. So if I move to the left, they will move my head to the right and move my eyes to the left at the same precise speed and degree, and that's what the function of the inner ear is. Poor balance function is a big problem. It's #1 cause of significant hospitalizations and morbidity in the older population. So fall is an issue, and so balance is very important. So our balance is controlled by the inner ear, as I said, your vision, and then nerves in our ankles and knees and stuff that control, that tell our brain how we're standing. And then that information goes to the brain moves the muscles, and that's how we hold our balance. Now, dizziness, which can be in different forms, and most of the patients who come in, they say they have dizziness, I have to a lot of times figure out, is it a lightheadedness problem, which is from blood not reaching the brain? Is it a vertigo problem, like room spinning, which is usually from the inner ear or sometimes from the brain? Or is it a balance problem, which is sometimes from the brain or sometimes from our inability to sense our feet because of problems with the nerves? So those are the problems we deal with. Now the question is, like, what are we doing about all these problems? And why do we do research? I spend about a day of my week, plus all my weekend, I should say, on research. Most of the week I'm seeing patients and doing surgery, and then I do research. So usually people say, what percentage of your time is clinical and what percentage is research? I say I'm 80% clinical and 80% research. So because there's so much that we're doing, I have to spend a lot of time overseeing a very large team of people. Clinical medicine really helps. For me, the way I think about it is I can only help, maybe 100,000 people in my career. That's like the max I could probably get out of my career is 100,000 people I can help. But if I can figure out something, I can help maybe 100 million people, with a solution that can solve many, many more people's problems. And if I could teach other doctors about things that we discover, then those other doctors can implement these treatments. And then also, again, the information that I'm able to gain from research can be multiplied beyond that. And so why do we do research? It's really to understand the mechanisms of the disease, develop new treatments, invent devices or medications, and find methods to prevent diseases. And really, without research, there's no advancement. Otherwise, we're practicing the same medicine as 50 years ago if we're not doing research and advancing the field. And really, we have to train other physicians and researchers learn these techniques and continue this on, because I'm only going to be around for so long. And so, my children are going to need doctors, and I want to make sure that they are going to have, good doctors. And so I need to teach other people how to treat these problems. So then, your grandchildren and your great-grandchildren will also have people to treat. It just won't be one generation of good doctors and they'll be done. So one of the things that we've really been trying to figure out is how do we regenerate those so-called hair cells. So these are pictures of the hair cells. This is with an electron microscope. So this is a picture of that hair cell made 100,000 times larger. And because it's now projected and made bigger, it's actually probably 1,000,000 times bigger than what the actual cell size is. So this is a tiny cell. These are the little hairs on top, and they're embedded in this gelatinous material. So that gelatinous material will move when sound hits it, and then the hairs will move and then produce the sound signal by sending a signal to the nerve, and then the nerve goes to the brain, and then brain figures it out. So most hearing loss is caused because we lose these cells. And if we can regenerate these cells, then we can restore hearing. Now, some animals have the capability to restore those cells on their own. So, I usually say if you take your bird to a concert, you will both get hearing loss. But 3 weeks later, your bird's going to have normal hearing again, but you will be left with that hearing loss. So wear earplugs when you go to a concert. The bird doesn't need earplugs. So one of the things we're doing in order to fix this problem is we've concentrated on this one part of cells called mitochondria. And mitochondria, which is these little blue things inside, so this is a cell, and these blue things inside the cell are actually, they produce the energy for the cell, and then they process this, what's called an oxygen radical. And in the process of metabolism, sometimes an oxygen molecule, which is two oxygen molecules stuck to each other, that's the way oxygen is present in the air, those two can break apart, and each has a single electron on them, and that can actually cause damage to tissues because that thing will go and stick to other molecules and break them apart. So the mitochondria actually take those what's called oxygen radicals, and takes those and fixes them and puts them back together with another oxygen, or uses other molecules to sort of prevent damage to the rest of the cell. But in that process, the mitochondria themselves get damaged. And over time, because our hearing is actually a very high metabolism area, because it has to do a lot of work in order to figure out speech, then we damage these mitochondria, and then the damaged mitochondria will then die, and over time, as many of these as you lose, then you lose that cell, because then there's no system to process energy inside the cell. Now, if you're interested, actually, mitochondria were actually bacteria that entered inside another cell, and then those cells, because they had now a method of generating their own energy, those cells were able to last better. And so now, like all mammals have mitochondria in them because it was advantageous to actually have cells that have another thing inside of them. So they have their own set of DNA, which is separate from the DNA that we have in our cells, in the sort of the nucleus of the cell. Anyway, so that's what the problem is. Now, what we have been working on is how can we prevent damage to those mitochondria, and how can we restore them? So one of the methods that we've been working on is using what we call mitochondrial transplant. And mitochondrial transplant is we take some muscle, get the mitochondria out of there, and then inject that into the ear to try to get them to go inside the cells, and then those cells will then have better mitochondria and it will last longer. So we just basically it's kind of like giving them a boost and making them younger, making the inner ear cells younger. Now, of course, this type of work, is not very easy, and it takes years and lots of money to get it perfected. Right now, we're in the cell culture. We're planning on doing experiments in rats very soon. And then another thing we're working in conjunction is using what's called CRISPR, and I don't know if you're familiar with CRISPR. CRISPR is a novel method of repairing genes. So basically, it's another thing that actually came from bacteria and fungi, where it's a molecule that can go and precisely find a part in the DNA and cut there and replace it with another segment of DNA. So CRISPR is now being used for gene therapy type experiments, whereas before our research was using viruses to try to inject cells with the right kind of DNA. Now we're using this repair mechanism that's going to fix it. So we're hoping that with CRISPR and our mitochondrial work, we'll be able to get hair cells to stay alive longer, and so then people will have better hearing long term. On tinnitus, we were talking a little bit before, but what tinnitus I wanted to mention is tinnitus, or ringing in the ears, is produced in the brain. It is produced in the brain in response to hearing loss. So if we can fix the hearing, of course that will make the ringing go away. But until we can figure it out, we have to work on making the ringing better for people until we can figure out how to restore the hearing cells. So we started back in 2006 when I got to UCI, and I like figuring out big problems, and I said, we got to come up with a way to solve tinnitus. So I sat down with one of my colleagues, Dr. Zhang, he's a PhD scientist in our department, and said, what are the things that we can do to help these people, and what are the things that work, and how can we get those for everybody? So one of the ways, of course, with the cochlear implant I was talking about, the electrode in the inner ear, if you stimulate the inner ear in someone who's deaf and has ringing, then their ringing goes away most of the time. So I said, what can we do in humans who have normal hearing, not the ones who have just damaged hearing? So we came up with actually this idea of using some sound that's targeted to that region where the hearing loss is. So if we can get more signal through there to the brain, then we can actually help people. So Dr. Zhang's research spun off this company that made this device. And in my research, I believe in sort of democratization of treatment. So I like coming up with very sophisticated solutions, but I also want to be able to have a solution that's accessible for everyone. If I can come up with a solution that costs $10,000, that's going to be only accessible to a small percentage of population. If I want to be able to ideally help everybody, I got to come up with a cheap solution. So this is our cheap solution, was to actually create a web-based system. Back then, the only treatment available, like this device cost about $3,000, and then there was another device cost $6,000. And you could only get these at very specialized centers. And so we actually developed this internet-based software where we could identify the pitch and actually do a test of the hearing, and then produce the sound and merge it with patients' own music, so they can listen to music, and then the sound therapy would work in the background. One of the other things that we found is that a lot of times people with ringing are a lot of times stressed and frustrated by it. So we came up with this cognitive behavioral therapy, which is what normally would be done for things like stress and whatnot. But again, you need to go to a psychologist, a lot of times not covered by insurance. It's hard for someone who lives in a rural area to access psychologists and specialized tinnitus centers. So we created an internet-based cognitive behavioral therapy where people will actually, essentially it's kind of like going to a therapist that will teach you all the things that a therapist will teach you. It's not as customized to the individual. They're not going to solve each individual person's problem, but we teach them all the things that a psychologist normally would teach in a process of CBT, or cognitive behavioral therapy. And we did a trial that was very effective. This was in 92 patients that we did a trial on. This is internet cognitive behavioral therapy. Worked much better than if they were to just be we put them on a wait list where they didn't get the treatment. Another thing we've been working on is actually we developed a drug for the treatment of ringing in the ears. We got some funding to start the trial. We've now enrolled 81 patients so far. There are 3 groups. 2 are getting 2 different types of drugs, and 1 is getting the control group. It's like a placebo sugar pill. And so far, that's actually been very promising as well. Another thing we started working on, this is sort of our sophisticated solution, and this is Professor Zhang, with whom I work on this research. And this was actually one of the first patients we tried this on. So this is a patient who'd had actually hearing loss in the ear and had really loud ringing, to the point that it was just really disturbing for her, and she'd had it for 20 years. So we started thinking, okay, if a cochlear implant can go in the inner ear and make the ringing quieter, maybe we could just stimulate the ear with an electrical stimulation. So this is a little probe we put in. We put it in through the ear, and you'd use this thing to hold it in place and stimulated the inner ear, and we could make the ringing go away in this patient who'd had it for 20 years. So that became very encouraging, and we started thinking about, okay, how can we have something? We can't obviously have people walk around with this thing around their head. So we need a device that's going to get implanted that can do this. So I started working with one of our electrical engineers at UCI, and this is actually the chip that's been built. This is what actually would get implanted behind the eardrum. And we would have a part on outside that's going to be like a hearing aid, and that stimulates the inside part, and then that will then send the electric signal to the brain. So then we can suppress ringing in patients. This would be the first actual cure for ringing. This would actually make ringing go away. All the other things I talked about, the sound therapy and the medication, just make the intensity so that it's not bothersome, but it doesn't make it completely go away. In hearing aids, we talked about sort of the issue with hearing aids, that a lot of people don't get it. But part of the problem is, as I said, the sound quality of hearing aids is not as good as people like it to be. And part of the problem is because you're taking a tiny speaker and putting it in the ear and then trying to expect that to produce very high quality sound. If you think about like really high quality speakers, these are big things. You want to get a wide spectrum of sound, you need a larger speaker. But obviously we can't get hearing aids that are that big. So what we thought is, what's the next best thing that we can do? There are implantable devices where it's this device is in the ear canal. There is something that's implanted behind the eardrum, and we move it vibrates the bones, and then you get better quality sound that way. So we then said, well, how can we do this from the outside? I'm going to go to here, and this is how we did it. This is a device that actually sits deep in the ear canal. This is our first prototype that we made, and sits right against that eardrum. And so it actually turns the eardrum into a speaker. So if you take the hearing aid out and actually hold it up in your ear, you don't actually hear anything until it touches the eardrum, and then it produces very high quality sound. And so this is actually our first experiment. This is actually my colleague in engineering that we worked on this together. This is one of our PhD students. These are some of our postdoctoral fellows. This is one of our resident doctors. She's now actually an ear, nose, and throat physician. And this is sort of me putting this device in for the first time into his ear. And so we put the device in this side and actually tested his hearing on the other side to compare how well the device functions compared to normal hearing on the other side. And it worked really well. So we're trying to develop it into a device that hopefully we can implant longer term. And this is actually another one of our engineers. We put it in his ear, and he kind of walked around and did some jumping jacks to make sure that this doesn't move, and it stayed pretty still. So we're hoping that we can get funding to make this device a little smaller so it can fit almost everyone. And then we're going to develop hopefully a fully packaged device that has everything and goes in the ear canal. Now, I'm just going to go back quickly and show you this one part of my democratization of treatment. This is a hearing aid app. So back when I was thinking about how can we make a cheap device, because hearing aids are expensive. And I was giving a lecture for the biomedical engineering students, and someone said, has anyone ever tried to use the electronics in a phone to make actually a hearing aid? And I said, well, no, we should do that. So we sat down together and worked on it and produced this app that basically does a hearing test, will determine what the levels of hearing is, and then will give the boost in those frequencies where the patient needs them. So it just, of course, needs someone to have their phone with them, on them all the time, to use it as a microphone and the electronics. But, you can get this app for like, $3, which someone who doesn't have any money at least can use their phone to use it as a hearing aid. All right, so let me go back here. So another area that we do a lot of clinical research on is migraine in the ear. So migraine, everyone thinks of migraine as a headache problem. So they say, well, I don't get migraines because I don't get headaches. So, but what I'm here to tell you is that you probably have had migraine, you just didn't realize you had it, because a significant portion of the population actually carries the genetic background for it. So the people that we know of having migraine headaches, which is about maybe 15 to 20% of the population, those are the people who have the bad headaches. Another 15 to 20% of the population has migraine, but they get other symptoms. And oftentimes they are like facial pain, like they call it, if people think of it as a sinus pain, or they think it's a sinus infection, or a lot of ear-related symptoms. So we've actually been sort of at the forefront of figuring out all these conditions that migraine causes, and we've written a lot of papers and done a lot of studies on role of migraine in the ear. So we were actually the first people to figure out that this disease called Meniere's disease, that people didn't know for 150 years what was causing this. We figured out that this is actually caused by migraine. And then we treated actually these patients with migraine medicine, and it was more successful than anything that's ever been done for this condition. Now, it's a relatively uncommon condition, but it's a problem because no one had a solution, and I really wanted to figure it out, and so we were able to figure it out. This fullness sensation that a lot of people think is from eustachian tube is actually, we found that it's caused by migraine. Sensitivity to sound, a lot of dizziness-related problems that people get. Sudden loss of hearing, we found, and we've been just doing now a study, a clinical trial with a medication combination that we have developed to treat this condition. Because still, even though we've done all of this work, still there are a lot of doctors who are just not as sort of up to date and the cutting edge on the research. So from the time something is discovered until 50% of physicians are practicing, it takes 17 years. And a lot of it is because they have to see that evidence over and over and over until they're convinced. And sometimes people are very set in their old ways. So we have actually now are doing the sort of the gold standard of studies, which is what's called a randomized clinical trial, where half the people are randomly getting the drug and half the people are randomly getting a sugar pill. And then we'll do this for 8 weeks and then see what the results are, to then prove that, okay, this is not me being biased and I'm putting like some patients in this group and some patients in the other group so I can get a better result. So we're hoping that with this type of study, we can actually convince other physicians to do this. So this is actually, all of these conditions are things that we have figured out over time are actually related to migraine. This is a term that we came up with to kind of cover all of these conditions that we see related to migraine in the ear. We talked about sort of the balance issues, and what we're now doing about it is, one of the problems with balance treatment is you have to go to a physical therapist. There is this very expensive device that only a couple places in Orange County have. It's like $80,000, and so very few places will get it. It requires a one-on-one physical therapist working with one individual at a time to try to fix their balance. And so we thought, how can we do this so that it's more automatic and easier and affordable for people and more accessible? So we started actually working on this insole, because what that big fancy machine does, it just has actually these sensors here that can sense pressure. And so we thought, well, let's just make an insole that can do that. So then you can put it in anyone's shoe and anyone can actually do this testing at home if they wanted. And then we actually started working on some games where, this is my collaborator in engineering, where we can get people to do the types of exercises that physical therapists have them do so we can strengthen their balance. And we've been working on a device that can actually replace the balance function. This is our sort of sophisticated solution to the problem. Just like the cochlear implant replaces hearing function, this will replace the balance organs function in people who've lost it. And then the rehabilitation, a lot of rehabilitation that's currently done, again, is one-on-one physical therapist telling you, like showing you stuff that you have to be looking at and moving your head and stuff like that. So with these Oculus headsets that was developed in Irvine, the patients can be given the therapy through there, and they can do all of the stuff that they need to do. And then the last couple of things I'm going to talk about is related to infections. Almost all children get ear infections. 90% get it by age 5. And I thought, I'm the ear specialist. There's no way I'm going to let my kids get this problem. And of course, both my kids, I kept looking every day, and I said, no, it's still not there yet, still not there. And then boom, it hit, and they both ended up getting a temporary hole in their eardrum, which was the worst thing for me. I just thought, oh my God, for me to have that happen. But this happens so quickly sometimes, and you just miss it. So now we thought, what can we do to make it easier? And I'm an expert at looking at ears, and I still missed it at an early stage. So I thought, what do we do to make this easy so that other doctors who don't look in ears a lot as much or aren't as expert at it to figure it out? So we thought about, okay, what is the eye actually doing? When I'm looking in the ear, what am I actually doing? I'm looking at colors, I'm looking at patterns, and so can we create a program that can actually figure that out? So we built this device that actually sends a certain wavelengths of light, and then will pick up the information, and then based on that can determine whether there is at least fluid behind the eardrum or not, because fluid is one of the signs of infection being present. And so this is what we call a smart otoscope. Most doctors, like general practice, like family medicine, etc. doctors, they're only 50% accurate. So if your child goes in to see a doctor and they tell you an ear infection, it's you tossing a coin versus going to the doctor is the same likelihood of being right. So we want to get that better. So we actually did a trial with our device, and we did 56 ears of children. And it was 98% accurate, so far better than any coin or physician. So now we're actually trying to develop the device a little bit further and do a larger trial of about 300 people, so then we can get this device FDA approved, hopefully. And this is actually a project that I've wanted to actually start. It hit the pandemic, and then it sort of, everything kind of fell apart. And in fact, actually, it was supposed to be here in 2020, but because of the pandemic, it got canceled. But one of the issues that we face as physicians, and even as parents or grandparents, I'm sure you deal with, or just patients, a lot of conditions cause nasal drainage, and a lot of times it's difficult to tell what is this from. Is this from a virus? Is this a bacteria? Is this an allergy? Even migraine can give you nasal drainage. And so initially we were working on allergy, cold, sinus infection, and migraine, but then COVID came in, and then it sort of, the person we had working on this project ended up working on a COVID-related project to develop a test for COVID, because if you remember, there was no test for COVID in the beginning. And so because of that, this project got sort of sidetracked, and we really want to start it up again if we can get the funding to do so. But I have a collaborator at UCI who develops tests, and we have a sort of an outline of what we would do. We just need sort of the funding to get this going. Anyways, this would be like a home test. Like, my children had a cold this past weekend, and what I would love to do is just test their nose and see, okay, what is this? Is this the flu? Is this a cold virus? Is this COVID? I mean, COVID we can test, but then the other stuff we can't test at home. So, I'm trying to figure out, should I treat it with a medicine for flu or not? So, you're kind of shotgun and treat sometimes when it's really not necessary. So this test would really help people in the future. So hearing imbalance, really, hearing is a primary method of communication, and Helen Keller, as you know, is someone who had both hearing loss and vision loss. And she was asked, which one would you rather get back if you had a choice for one of them? And she said that vision allows us to just see things, but hearing allows us to connect with people. And she would rather have her hearing back, and she wasn't as interested in her vision if she had a choice. And balance is one of the things where we take for granted, but it's really the sixth sense that really don't think about, but we don't think about it until we lose it, and that becomes an issue. So our hope and goal is to develop an ear institute at UCI. We want to find ways to prevent and treat hearing loss, balance disorders, all the other things we talked about. And really research and education is key to do this. And we want to build this world-class institute that can have top-notch care, do top-notch research like we're doing, and expand further, and then educate the next generation of scientists and physicians. So, we need community leaders like you to help support this type of effort so that we can bring this to fruition. This is my team. As I said, we have a very large team, and I spend so much of my evenings and weekends emailing and meeting with my team over all the various projects that we have going on. I'm very, very fortunate to have such a great group of people to work with, because I wouldn't be able to do all this stuff we're doing without them. And that's all I have. I'll be happy to answer any questions.
Thank you, Dr. Djalilian. I'm going to go out into the audience and with the microphone, so if you raise your hands, I will come out and you can ask your questions.
Yes, I'd like to ask you, there's a lot of inter-ear surgeries that I'm seeing here, inner ear, and placements. Do ENTs do that surgery?
So placement of devices into the inner ear is usually not done by a general ENT. It's usually done by like an ear specialist like me. But a very small percentage of people really needs that device placed. Most people could be helped with a hearing aid, with hearing loss. But if someone has severe hearing loss or is unable to get benefit out of a hearing aid, then that would be a device that the cochlear implant would be something like someone like me would place, yes.
What should I do if I have hearing loss and I come to you? Can you help me out in correcting that?
It depends on the type of hearing loss you have, but if you have the most common type of hearing loss, which would be the combination of age-related and noise-induced hearing loss, then the first thing would be to use hearing aids. So I would recommend hearing aids. The things that you can do to sort of help slow down the progression of hearing loss are taking a multivitamin that has vitamins A, C, and E. So ACE, ACE. Those three, and a multivitamin generally has those three in them, but just make sure they do if you're taking one. Having good control over your blood pressure and blood sugar. Those two, as I said, if they're high, your hearing will go down faster. Of course, not smoking, which most people don't, but just not being around people who smoke at least. And avoiding very loud noise exposure. So, if you go somewhere where it's very loud, wearing earplugs and things like that. Okay.
More questions? Here.
Can you explain about otosclerosis and treatments for that?
Sure. So otosclerosis, and I will show you the anatomy here. So otosclerosis is a condition that affects the hearing bones behind the ear, the third bone specifically. So you get some growth of bone that sticks to that third bone, so then it doesn't vibrate very well. Because if you think about these bones, they have to have the ability to vibrate, so they're actually kind of held by these little rubber bands. But if there is calcium or bone growth and it sort of stops that from vibrating, you're going to have a hearing loss. Now, what can be done, you could use a hearing aid. That's sort of one option to just make the sound louder. The other is to actually go and take out the bone that's sort of not vibrating anymore and replacing it with a prosthesis in its place. And that generally works about 95% of the time.
Yes, kind of a unique question. I have had surgery for acoustic neuroma, and I lost the hearing in one ear completely. I'm just wondering if there's some treatment for that.
Sure. So hearing loss in one ear creates a problem in that we have difficulty understanding speech in a noisy environment, so we rely on having two ears for that. We also lose the ability to localize sound because we need two ears for that. And the last is really the problem of when you're sitting in let's say around a table, then somebody talking on your bad side, you won't hear them, and so people think that you're ignoring them. Or you have to kind of turn and go like this to sort of hear. So now, the only solutions we have are really intended to fix that last problem, which is people talking on the bad side, which is, it would be a hearing aid that goes on the bad side. Let's say my right side is the bad side. It goes on that side, but it's actually not amplifying sound. It's just a microphone. It picks up the sound, and then it sends the signal to the actual device, which is on the other side, and that puts it into the ear. So then if somebody talks on my right side, I can still hear them. I don't have to turn. There is now, just as of last year, the FDA approved the cochlear implant for people who've lost hearing in one ear, but would have to have their nerve present, which I don't know if your nerve is still there or not. And you have to have lost hearing within 10 years of presentation to be able to get the implant. And so people can actually now get an implant, have like the cochlear implant in one ear, and then have their normal hearing in their other ear. So those are the potential solutions. There are some what are called semi-implantable devices, which is a device that goes under the skin and sends the sound through the bone to the other ear. And you have an outside part that has like the battery and the microphone and stuff, and sticks to it with a magnet sort of under the hair, that then sends the sound to the internal device. That internal device vibrates the skull at a tiny level. You don't feel it, and it produces the sound that then goes to the other ear. Those are called bone conduction devices. So it sends the sound to the good ear, yeah. So you're still using your good ear as the only ear, correct?
First of all, thank you very much for this presentation. We just love medicine in your backyard. So thank you. Have you heard, since some patients have received the vaccine, that they have developed a ringing in the ears, possibly from the vaccine? Had you heard that?
Yes. Now, I should say that, probably 90 to 95% of the time when patients come to me with that issue, I ask them, well, when did the ringing start in relationship to the vaccine? They're like, well, I got the vaccine 6 months before it. Well, it's not from that. So any vaccine or any inflammatory process in the body, and that could be even the infection itself, so a COVID infection itself, will cause this large inflammatory process. The brain sees that inflammatory process and realizes that there is something wrong in the body. That then, the brain then starts this stress response. So it produces these hormones in response to seeing this inflammatory process. And that production of those stress hormones activates this process related to migraine. And that migraine process is what makes the brain much more sensitive. And you start then hearing this, or listening to these internal sounds that actually existed before that the brain was ignoring. So a lot of times people have had a little bit of hearing loss, and after age 20, everybody gets hearing loss in the very high pitches. So age-related hearing loss starts at 20. It's just in the pitches that we don't use for speech, so we don't realize we're actually losing it. So you lose those cells, you start producing this activity in the brain in response to that loss of cell. But your brain can go many years and not notice that signal until something happens that creates an inflammatory response that then makes the brain get sensitive, and then the brain starts listening to it, and then you hear it as a ringing. So I tell patients, it was there before, you're just now hearing it, and our goal treatment is really to make your brain forget about it again. And so that we use a combination of medications intended to treat migraine. That's what our clinical trial is for. And then we use sound through the ear to suppress it. That's what the sound therapy work that we have done. So that's currently the way we treat it. But can it? Yes. Are you just as likely to get it from the infection as you are from the vaccine? Yes. Can you get it from any vaccine? Yes, you can get it from any vaccine. Should that stop anybody from getting vaccine? No, definitely not. Because the ringing is treatable. But COVID is still, there's still 300 people a day who are dying in the United States of COVID. So it hasn't gone away completely.
More questions?
Hello.
Hi.
If one does not have a temporic membrane or the inner bones, is the only option for hearing the cochlear implant?
So if the inner ear is functioning, meaning where the cells are functioning, but you just don't have the eardrum or the little bones, I mean, we could just make the sound very loud and then vibrate the fluids inside the inner ear. So you could just use a hearing aid. But let's say if somebody doesn't want the hearing aid, we could use one of those bone conduction devices I was talking about. So the device goes under the skin here, and it sort of is embedded in this bone. So it creates vibrations of the bone. That vibration then goes to the inner ear, and then you can actually hear. So if the inner ear is working, we still want to use the inner ear in its native state, because the quality of hearing is much better with your normal inner ear rather than a cochlear implant. Cochlear implant still doesn't sound as crisp, clear as normal hearing does. Correct, yeah. Your inner ear has to be significantly damaged for us to consider the cochlear implant.
Mark? Oh, over here. Over here.
Do you have any recommendations for a hearing aid with good clarity?
So hearing aids with good clarity, I mean, right now there are two companies that have ones that have a broader frequency range than others. They are called Phonak, P-H-O-N-A-K. Paradise is called Phonak Paradise. And then the other one is called Resound, R-E, like R-E sound, Resound. And then the model number is called One, like O-N-E. So those have a broader frequency range. Now, one thing I should mention always, if in case a question comes up, just so you know. So hearing aids are like cars. So you have the top of the line, and you have sort of the base model. So the Toyota Corporation makes the Lexus, and it makes the Corolla. They're both cars. They both hearing aids. The same company makes different levels of devices. So the best devices are the high-end devices. They have all the features that help reduce noise in the background. They're a lot more adjustable. They usually have a broader frequency range, etc. Now, not all places sell the highest end devices. So some places, in order to sort of create the appearance that they are, hey, ours is cheaper than everyone else, and like I won't mention the name of a large warehouse company that sells hearing aids, but they say, hey, look, our hearing aids are cheaper than everywhere, but they're not selling you the best. That's why it's cheaper than everywhere else, because they're selling you the Camry and saying, oh, look, we're cheaper than the Lexus. Well, of course it's going to be cheaper, because it's not the same level device. So that's sort of the one thing that is always important to kind of keep in mind, that if you want to try hearing aids, and if you can afford them, get the best ones. And if you don't like them, then you don't like them. But you have 45 days, you can return them and get your money back. But what we don't want is people trying a low-level device or a mid-level device and then saying, oh, I tried hearing aids and it didn't work. And it would have worked if they just used a better device.
My question is that if you are wearing hearing aids and you're aging, is it still going to get worse with age?
Yes, yeah, the programmed sort of loss of cells is something that's genetically programmed. Some people lose it faster, and some people have, this incredible protection against it. So I have like 90-year-old patients who have this incredibly good hearing, like a 25-year-old. That's a rarity, but they have this genetic protection that, and we're trying to actually understand why it is that some people are so well protected. But yeah, the genetic hearing loss will continue even if you wear hearing aids, yes.
Okay, I just would like to second a lot of what you've been saying. I've been wearing hearing aids for 52 years. So I've seen them go from the analogs to the digitals and 1 ear, 2 ears, and all that. And I would support what you have said. Don't sell yourself short. I actually use an Oticon, which I think is comparable to the Phonak, but I do very well with it. But don't be afraid to get them. They're well worth it.
And I just had a question here. If you would repeat the hearing aids that you recommended?
Oh, sure. The ones that we recommend, and Otocon's a good hearing aid too. I mean, there are only about 5 companies that control probably close to 90% of the market worldwide. And they're mostly European companies. They bought out a lot of the US-based companies. There's only one company left in the US. So Phonak Paradise, Phonak is like a phone but with a K at the end. And then the other one is a Resound, or R-E Sound 1, O-N-E.
Sir, go ahead.
Yeah, I have a question about like someone with a profound hearing loss. When they get amplification, it's making a lot of the sounds much louder. Is that damaging the ear?
No, hearing aids sort of, they top out at a certain level, so they're not going to damage hearing. And it's hard to get damage to your hearing from speech, because speech has a lot of breaks in it. Whereas, the same level with music, you can damage it, because music is continuous. So your hearing damage occurs as a result of the loudness and the duration. And so if you have like a concert where it's like, 2 hours in a row of loud music versus somebody talking for 2 hours in a row at a loud level, you're not going to get hearing loss from somebody talking. But the music, because it's continuous, you'll get damage from.
Any more questions? I comment, my mother used to get migraine headaches, and she called them the blind staggers. Is there a relationship between the eyes and the ear when that happens?
So what we have found is a lot of patients who get the ear-related migraine can tend to have the eye-related migraine as well. The eye-related migraine is because the blood flow changes to the back part of the brain, which is the so-called occipital area, and that's the part that affects the vision with the jagged lines and the blindness and whatnot. So it's really the change in the blood flow to the back part of the brain is what causes the visual changes of migraine. The ear-related migraine occurs also because of because we have the circulation to the brain there's 2 big blood vessels that go up front and the 2 in the back. And the ear migraine is also back circulation, so this posterior circulation, as we call it, migraine. Whereas like the more anterior stuff will give you the more other types of common type things like headaches and stuff that we see.
Let's say that I have minor hearing loss, but I have enough money to get a Phonak Paradise one. Can I go get one of those, and then as I lose more hearing, can they upgrade me without having to pay a bunch of money?
Oh, good question. So again, hearing aid, think about it as like a car. You take good care of it, you keep it sort of tuned and whatnot, it will last you a long time. The question then becomes, let's say I have a car that's from 10 years ago. It still runs, but now I want the thing that's like the accident prevention thing, where it's like stops on its own. But that's a new technology that didn't exist back then. And now there is this new technology. And if I want that feature, then I will have to go buy a new car. And same is for hearing aids. So you have the hearing aid, it's going to still work. Even if you lose hearing, they could just tune it and make it louder. However, there may be some new technology that will come out 5-10 years from now. Then you say, well, I really want that, and you just have to get new devices in order to get that. But you can't update the software if that's what you're
Not like
asking.
a Tesla, like they'll say you have a
No,
update coming
yeah.
and they'll do it.
No, I mean...
Not yet.
Not yet. I mean, yes, I think probably some of the over-the-counter devices may potentially do that. But at the end of the day, these companies want to make money, so they're not going to make it cheap, for you to continually be able to upgrade it forever. They're going to want to make it so that you end up buying more.
Thank you.
Do we have one more question?
The last question?
This will be probably our last one.
The kind of a sister company, it's owned by the same company called Unitron. They are upgradable. You can buy a level 5 and make it up to a level 9. It costs you about the same as if you paid for the level. I mean, the difference is about the same, but from the beginning when you bought them, say you paid $2,000 for the certain level, and it would have been $5,000 for the other level, then the $3,000 is a difference. But they do have, that's the only company I know that actually will allow you to start at a certain level and then pay up to the next level.
So yeah, that's a good point, because what's inside the actual device, a hearing aid, for a low level and mid level and high level, it's the same. They just deactivate parts of it for the lower, because they don't want to have multiple lines of production. They just produce one and then deactivate the electronics of some components. So that way, so like for example, some devices that you can, like as I was saying, the big box warehouse company that sells hearing aids, that place, the hearing aid you're getting, if you open it and look, it looks the same as a higher end device, but that doesn't function like a hearing because they've turned off a lot of the stuff in there.
Thank you, Dr. Djalilian. You've given us so much information about the extraordinary research that you were doing, and with the tinnitus, if the military is the biggest cause of this, are they supporting your research?
No, it's actually amazing that the military does not fund a lot of research in this area. We've actually applied for grants through the VA, and we thought, because they were looking for exactly what we were making, which is a way to sort of be able to treat people in a remote location. And we found out they actually didn't give the grant to anybody that year, even though we had multiple grants that we sent and others that our friends sent. Because a lot of times it's all politics, unfortunately, because the VA likes to fund the researchers who are at the VA, because they want to sort of say that, look how great our researchers are at the VA system. So they don't fund outside studies, even though they're technically open for everybody to apply for. So we haven't. Most of our work has been supported through philanthropy from patients and friends.
It's really, really wonderful. So thank you. Can we thank him for coming out tonight? And let me announce our next meeting will be on January 23rd. It's on memory disorder, and maybe we'll learn more about the relationship between that and hearing issues as well. So have a good holiday season, and we'll see you in January.